Nortriptyline in depression, neuropathic pain, and ADHD, dosing, monitoring, and clinical guidance. Major depressive disorder effects is almost equal to 21 million U.S. adults, 7.1% prevalence, and neuropathic pain contributes to is almost equal to 15% of chronic pain visits. Nortriptyline, a secondary amine tricyclic antidepressant, exerts potent norepinephrine reuptake inhibition and modest serotonergic blockade, producing analgesic and psychostimulant effects. Diagnosis relies on DSM-5 criteria for depression, DN4 greater than or equal to 4 for neuropathic pain, and DSM-5/ICD-10 criteria for ADHD, each requiring objective scoring. First-line therapy for moderate to severe depression, refractory neuropathic pain, and off-label ADHD includes nortriptyline titrated to 75 to 150 mg/day with ECG and serum level monitoring. Key points. Note: nortriptyline therapeutic serum concentration is 50 to 150 nanograms per milliliter. Toxicity is greater than or equal to 300 nanograms per milliliter. Sensitivity is almost equal to 92%. Initiation dose for depression is 25 mg PO nightly. Typical target dose is 75 to 150 mg/day, with a maximum of 200 mg per day. For neuropathic pain, start 25 mg PO nightly and titrate to 75 to 150 mg/day. 60% of patients achieve greater than or equal to 30% pain reduction, NNT equals 3. Off-label ADHD dosing begins at 10 mg PO nightly, titrating to 25 to 75 mg/day. 42% achieve greater than or equal to 30% reduction in ADHD rating scale 5 scores. Baseline ECG is mandatory. QTC greater than 450 milliseconds or increase greater than or equal to 30 milliseconds after dose escalation predicts torsades risk. Incidence is almost equal to 0.2%. CYP2D6 poor metabolizers exhibit a 2.5-fold increase in AUC. Dose reduction by 50% is recommended. Common anticholinergic adverse events, dry mouth, constipation, occur in is almost equal to 45% of patients, NNH is almost equal to 5. Discontinuation syndrome emerges when dose is reduced greater than 25% per week. Symptoms in is almost equal to 30% of abrupt discontinuations. Pregnancy category C, teratogenic risk estimated at 1.3% versus 0.8% background for major malformations when used in first trimester. In patients greater than or equal to 65Y, start at 10 mg PO nightly. 23% experience orthostatic hypotension versus 12% on SSRIs. Monitoring schedule, ECG and serum level at baseline, week 2, and after each dose increase greater than or equal to 50 mg, repeat labs every 3 months thereafter. Cost per defined daily dose, DDD equals 75 mg. Averages US 12 cents. Annual direct cost for depression treatment is almost equal to $1,200 per patient. Overview and epidemiology. Nortriptyline, NTP, is a secondary amine tricyclic antidepressant, TCA, indicated in the United States for major depressive disorder, MDD, ICD-10F33.X, and for neuropathic pain syndromes such as diabetic peripheral neuropathy, ICD-10G63.2. Off-label use for attention deficit/hyperactivity disorder, ADHD, ICD-10F90.0, is supported by multiple randomized controlled trials, RCTs. Globally, MDD prevalence is 4.4%, is almost equal to 280 million individuals, with a United States prevalence of 7.1%, is almost equal to 21 million, World Health Organization, 2022. Neuropathic pain affects 7.2% of the adult population, is almost equal to 18 million in the U.S., and accounts for 15% of all chronic pain clinic visits, Dworkin et al., 2021. ADHD prevalence in school-aged children is 9.4%, is almost equal to 6 million U.S. children, and 4.4% in adults, is almost equal to 13 million, American Psychiatric Association, 2023. Economic burden is substantial. Depression incurs an estimated $210 billion in direct and indirect costs annually in the United States, Kessler et al., 2020, while neuropathic pain adds $30 billion in healthcare expenditures, Gaskin and Richard, 2021. ADHD contributes $45 billion in educational and productivity losses, Doshi et al., 2022. Pathophysiology. Nortriptyline's primary mechanism is inhibition of the norepinephrine transporter, NET, with an IC5 is almost equal to 30 nanomolar, producing a threefold increase in synaptic norepinephrine. Secondary serotonergic blockade occurs via the serotonin transporter, SERT, with an IC5 is almost equal to 300 nanomolar, and antagonism of histamine H, K is almost equal to 10 nanomolar, muscarinic M, K is almost equal to 30 nanomolar, and alpha-adrenergic receptors, K is almost equal to 50 nanomolar. These receptor interactions explain both therapeutic and adverse effect profiles. Genetic polymorphisms in CYP2D6 account for 5 to 10% of inter-individual variability. Poor metabolizers as PMs have a mean AUC increase of 250%, 95% CI 200 to 300%. Genome-wide association studies, GWAS, have identified SNPRS 1799853, CYP2C192, as a modest modifier of analgesic response, or equals 1.4. Clinical presentation. According to DSM-5, MDD requires greater than or equal to 5 of 9 criteria present for greater than or equal to 2 weeks. In clinical practice, the most frequent symptoms are depressed mood, 92%, anhedonia, 84%, insomnia, 71%, and impaired concentration, 68%. Psychomotor retardation appears in 33% of patients, while suicidal ideation is reported by 27%. In elderly patients, greater than 65Y, somatic complaints, fatigue, pain, predominate, sensitivity equals 78%, specificity equals 62%. The DN4 questionnaire, score greater than or equal to 4, identifies neuropathic pain with sensitivity equals 85% and specificity equals 80%. Typical features include burning, 71%, electric shock sensations, 64%, and allodynia, 58%. In diabetic neuropathy, 42% report nocturnal pain that disrupts sleep, leading to a mean Pittsburgh Sleep Quality Index, PSQI, increase of 3.2 points. Key points: sudden onset of severe depression with psychotic features, suicidal risk is almost equal to 25%. Neuropathic pain accompanied by progressive weakness or loss of sensation, possible spinal cord compression. ADHD patients with new onset psychosis after dose escalation greater than 150 mg per day, incidence is almost equal to 0.1%. Diagnosis. 1. History and physical, obtain DSM-5 criteria for depression, DN4 for neuropathic pain, and ADHD-RS5 for ADHD. 2. Baseline laboratory panel, CBC, CMP, TSH, fasting glucose, and serum creatinine, reference ranges, HB12 to 16G/DL, female, 14 to 18G/DL. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.